Hello there guys, welcome to this tutorial on asthma. We'll be learning about its pathophysiology, how to diagnose it, and treat both acute and chronic asthma. So let's get started. So some disclaimers so that I don't get sued, hopefully, in this video. So before we learn about asthma, the first concept to learn is the difference between obstructive and restrictive lung disease. Asthma is often described as an obstructive lung disease. So what does this mean? Essentially, obstructive lung disease is characterized by airway disease with the lung volume often being preserved. The problem with the disease is that there is difficulty getting air out of the lungs. Restrictive lung disease, meanwhile, typically has both airway disease with a loss of lung volume, but there's difficulty getting air into the lungs. This is because of reduced compliance but high recoil. There are four main types of obstructive lung diseases as shown here, and in this video we'll be focusing on asthma. So what is asthma? Asthma is an airway hypersensitivity disorder which is characterized by both type 1 and type 4 hypersensitivity. This hypersensitivity is to harmless allergens and triggers. Type 4 hypersensitivity causes chronic airway inflammation, causing the chronic symptoms of asthma. This is due to cytokine release by type 2 helper T cells, Th2 for short, as shown in this image. And what this results is that there is raised eosinophilia, and IgE production, which are important mediators in an acute asthma attack, which we will see later in this tutorial. Now, how do patients present? If you are asthmatic, you probably know this already, but generally in people with asthma, symptoms are worse at night, often due to low cortisol, and early mornings due to the physiological peak airway narrowing. Essentially, during the early hours around 3-4 a.m., your airway is the smallest during that time, so therefore there's a higher chance of having an asthma attack around those times. Another characteristic sign of asthma is the polyphonic wheeze. We call it polyphonic because it's involving the small airways. And many asthmatics also suffer from non-productive dry cough, and this can be associated with the wheeze. Difficulty breathing, i.e. dyspnea or chest tightness, can occur on exercise, exposure to drugs such as NSAIDs like aspirin or ibuprofen, or when they are exposed to cold environments, and also when taking beta blockers. Hence why when prescribing beta blockers is always need to double check that if a person is asthmatic or not. Generally, patients who have atopy, the term that we use to say for people who have a history of allergies or hay fever or eczema, these people are at higher risk of developing asthma. So to diagnose asthma, NICE advises to do the following things. So this is a bit of a boring thing, but you just got to memorize it, unfortunately. Firstly, the clinical history is important, but then we need to do some objective testing. The first line objective testing is the fractional exhaled nitric oxide. So raised nitric oxide would suggest there is chronic airway inflammation. Equally, if this can't be done, you could measure the serum eosinophil count, and if there is a raised eosinophil, then again it's suggestive. If these are negative but you still have a high clinical suspicion, you can do a spirometry with a bronchodilator reversibility. Essentially, you give someone salbutamol and measure the spirometer before giving salbutamol and after giving salbutamol. And if the FEV1 increases by 12% or by 200 mils, this will support the diagnosis of asthma. Don't ask me where they got those numbers because I don't know. Again, the third line, what you could do is you can do a peak expiratory flow test, and essentially what you ask the patient to do is to measure their peak flow morning and night for 2 weeks, and if there's a variability of about 20% in the highest and the lowest reading, the test is considered positive. Now, if all these tests are not conclusive evidence for asthma but you still are suspicious about it, then refer to someone who knows a bit more than you about asthma. So as a respiratory physician would be inappropriate. Now, how do we manage asthma? So NICE advises the following for children under the age of 12. So the first step is to start on a low dose inhaled corticosteroid. Often the colloquial term is the preventer or the brown inhaler. This contains steroids like budesonide or beclomethasone, and a SABA, a short-acting beta agonist, such as salbutamol, also colloquially called the blue inhaler or reliever. The next step is, if this is not controlled, just make sure that the patient is adhering to the treatment. If not, then you can trial a leukotriene receptor antagonist. Montelukast is the go-to generally. If the LTRA doesn't work, stop it and start a LABA, long-acting beta agonist, like formoterol or salmeterol, with the inhaled corticosteroid. And if it's uncontrolled still, maybe try increasing it. But, at this stage, it's beyond your limits and you want to refer the patient to someone more knowledgeable than you. Now, there are new guidance offered by NICE from 2024. The previous one I showed you was the old guidelines, which is still applicable. However, what the NICE is promoting to do is to start something called MART. As you see highlighted in the box here, for children under the age of 12, you can consider starting a low-dose MART. If it's not, then you give a moderate dose MART and so on. But as you can see in the small box on the bottom left, as of November 2024, this is currently not licensed for children under 12, so many may be likely on the old regimen. So now, what is MART? The reason why MART developed was people used to have two inhalers, the brown and the blue inhaler, and some genius thought, why do we need two, and let's just mix it as one. So instead of two inhalers, patient can carry one inhaler. And MART stands for maintenance and reliever therapy. It's a combination inhaler. It contains both the inhaled corticosteroid and a LABA. The most common one is formoterol. The usual combination tends to be, the brand name tends to be Symbicort or Foster. I don't know which one is better, but in my clinical practice, I prescribe either of them depending on what the respiratory specialist nurse advises me. So both of them are, in my opinion, good. Now, how do we manage chronic asthma in people over the age of 12? So NICE is more stringent on this one and advises to start someone on MART therapy straight away. Initially start it as a PRN dosage, so as needed, with low-dose inhaled corticosteroid and formoterol. If that doesn't work, then make it into a regular low dose. If this doesn't work, just make sure that the person definitely has asthma, and if you still are convinced that they do, then refer that patient to a respiratory physician. Now let's look at the pathophysiology of an acute asthma attack. Acute asthma attack is a type 1 hypersensitivity reaction. So in this scenario, there is a mast cell degranulation. So mast cells contain a lot of histamines, and these histamine molecules are released, which causes the effect of vasodilation, itchiness, bronchoconstriction, narrowing the airway, increases the mucus production, and airway edema. Now, I'm not going to delve deep into the details of how the mast cell degranulation or how the IG stuff works, because that's pre-clin medicine, and we here will focus on clinical aspect mainly. Now, so you understand hopefully about what's happening in an acute asthma attack. What do we do as clinicians? We try to categorize the severity, and this can guide us on who to involve quickly, as in would you want to involve ITU, non-invasive ventilation, and so on. Essentially, again, this is just a number memorizing thing. In my opinion, I would say to remember the life-threatening features of asthma, which is the peak expiratory flow rate less than 33%, or oxygen sats less than 92%, or if someone has a normal CO2 on a blood gas, is that saying that they are storing up the carbon dioxide and they're not ventilating enough to push it out. And if someone's having a silent chest, again, that means they are not having enough strong respiratory effort. So how do you treat it? The acronym we tend to use in medical practice is OSHIME. Essentially, what that stands for is you give oxygen as required. You start the patient on nebulized salbutamol, generally 2.5 milligrams, and you need to give them some steroids. We generally give IV because you want to treat ASAP. And equally, if IV hydrocortisone is not available, you can give a strong dose of oral prednisolone orally, about 40 milligrams. And you also start the patient on ipratropium nebulizers. It's around 0.5 milligrams. So you give salbutamol, ipratropium, essentially until that patient is recovering from the asthma attack. And if these are not helping, then you probably need to call IT by this point. And also you can trial in the meantime for magnesium sulfate, which is a depressant, and escalate to ITU. Once a patient is recovering from an asthma attack, you need to give a prophylactic dose of steroids for about 3 days. And again, this tends to be prednisolone, 40 milligrams, once daily for 3 days. Okay, we've come to the end of this tutorial. Hopefully you learned something from it. If you did, please make sure to like and subscribe. And I will see you in the next one. Have a good day.